Hi everybody and welcome to our module on HIV. HIV is the human immunodeficiency virus. It is an RNA retrovirus, and it's called a retrovirus because it uses the enzyme reverse transcriptase to convert its RNA genome into DNA. The primary target of the infection are CD4 positive T helper cells, although the virus can also infect other cells like macrophages, as we'll talk about in a minute. It leads to the acquired immunodeficiency syndrome, or AIDS, and when people develop AIDS, they are susceptible to unique opportunistic infections. And the natural host of HIV is humans. It jumps from person to person in a sexually transmitted manner. HIV has a diploid genome, and this means that it carries two copies of positive stranded RNA inside of the virus. The RNA is tightly bound to several key enzymes. The first one is reverse transcriptase, which we talked about before. This is what makes DNA from RNA. The second enzyme is aspartate protease, and this is responsible for cleavage of proteins. We'll talk more about this in a minute. And the third enzyme is integrase, which integrates the DNA of the virus into the host cell's DNA. And these enzymes are very important because when we talk about drugs to treat HIV, there are drugs that are reverse transcriptase inhibitors and protease inhibitors and integrase inhibitors, and they block these three enzymes right here. The capsid of HIV has an unusual shape. It's cone-shaped or conical, and it's made up of multiple copies of a protein called P24. And this protein is very important because you can detect antibodies to P24 to diagnose HIV infection. Another important thing to know about P24 is that it's not a variable protein, so it has a consistent structure as the virus replicates. This means that the body can mount an antibody response, but unfortunately the antibody response is not strong enough to neutralize the virus. HIV has a phospholipid envelope that's derived from the membrane of human cells, and this envelope contains a protein called ONV. And the cap of the ONV protein contains some glycoproteins that you need to know about. The first one is called GP120, and this glycoprotein is important for attaching to T cells. The second glycoprotein is GP41, and this is important for fusion and entry into T cells. And both of these are formed as a single protein from a gene, which we'll talk about in a minute, and the single protein is called GP160, and it then gets cleaved to become these two smaller glycoproteins. One high-yield thing to know is that the gene that encodes for GP120 mutates rapidly. Therefore, the GP120 glycoprotein exhibits a feature called antigenic variation. There is a portion of GP120 called the V3 loop that is highly immunogenic, and this is the portion that antibodies will be developed against. Unfortunately, it varies significantly because of all the mutation and the antigenic variation, so it's very difficult for antibodies to neutralize HIV by creating responses to GP120 because that protein is varying so much as the virus reproduces. This is a drawing of HIV, and you can see that there are glycoproteins sticking out of the lipid membrane. These glycoproteins include GP120 for docking and GP41 for fusion and entry. You can also see that the capsid has a conical shape and that there are enzymes inside the capsid bound tightly with the RNA. There are three main genes that encode for the major parts of the HIV virus. The first one is called GAG, which codes for parts of the nucleocapsid. The second one is called POL, which codes for many of the enzymes. And the third one is called ENV, which codes for the envelope proteins. All three of these genes code for a long polypeptide that will be cleaved to form smaller proteins that are important for the functional virus. GAG codes for a long polypeptide that's broken up into a number of pieces, including P24, which is important for the capsid. The POL gene encodes for a long polypeptide that is broken up to form several enzymes, including reverse transcriptase, integrase, and protease. And then, as we talked about before, the ONV gene codes for the GP160 protein, which is cleaved to form GP120 and GP41, which are important for the envelope. There's an important tie-in with pharmacology here. The protease enzyme is the enzyme responsible for cleaving the long polypeptides into the smaller pieces. So later, when we talk about HIV pharmacology, we'll talk about drugs that inhibit the activity of protease. And when you inhibit that activity, the virus is no longer able to break up the long polypeptides into the smaller pieces, and therefore it cannot become functional. Besides the three main genes, there are a number of other genes called regulatory and auxiliary genes. TAT and REV are two genes that are required for viral replication. We know this because variants of HIV that lack one of these genes do not replicate. TAT activates transcription of genes, and REV appears to be important for transporting mRNA from the nucleus to the cytoplasm. There are then a number of what's called auxiliary genes. Variants of HIV that lack one of these genes can still replicate. That's why they're called auxiliary genes. The function of each of these is still being studied and not completely understood. One of them is NEF, and it's responsible for decreasing CD4 proteins and MHC1 on T cell surfaces. The actions of these other ones are not completely worked out yet. There are two receptors on the surface of immune system cells that HIV virus particles like to bind to gain entry into cells of the human body, and those two receptors are called CCR5 and CXCR4. And different virus particles have a tendency to bind one or the other of these receptors, and depending on which receptor they bind, that will influence which cell types they tend to infect. This is called HIV tropism. So some virus particles are called CCR5 tropic, and these virus particles tend to replicate predominantly in monocytes and macrophages. They're sometimes also called M-tropic virus particles. CCR5 tropic viruses can also infect dendritic cells and use the dendritic cells to get traffic to lymph nodes. The other type of virus particle is called CXCR4 tropic, and these types replicate more efficiently in T cells. They're sometimes called T-tropic viruses. So one thing you should know is that early after someone is infected with the virus through sexual transmission, the viruses in their body will be predominantly the CCR5 type. That's because this is a type that's usually transmitted sexually, and it finds its way into macrophages and monocytes in the epithelial layer of the uretogenital tract. Once the virus has been in the body for a while and replicating later on in infection, this CXCR4 type of virus will begin to evolve, and you will see this later on in infection, not right after someone has been infected. Another important concept to appreciate is that there have been mutations of the CCR5 gene identified, and they're associated with decreased susceptibility to HIV infection, and this should make sense to you. Like I said before, the CCR5 tropic viruses are the ones that get transmitted sexually and initially infect monocytes and macrophages, so if you have a mutation in your CCR5 gene, you will be less likely to get infected. So here's an illustration of the accepted model of how HIV gains entry into cells of the human body. This pulls together what we've been talking about in the last few slides, and this is the type of thing they're likely to ask you on step 1. So the HIV virus is shown in pink. These pink structures on the surface are GP120 glycoproteins. The little loops are the variable regions. These 4 circles here in blue are CD4 molecules, and HIV attacks cells that have CD4 on their surface. Now you probably know that many T cells have CD4 on their surface, but what you may not realize is that CD4 is also found in monocytes and macrophages and dendritic cells, and all of the cell types that HIV can infect. So GP120 and CD4 will bind in the first step of HIV entry into cells, but that's not enough. HIV needs to then bind to one of the co-receptors, either CCR5 or CXCR4. And as we just talked about in the last slide, some HIV virus particles prefer to bind to CCR5 and some to CXCR4. Once GP120 has bound to CD4 and one of the two co-receptors, then GP41 can serve its role as an anchoring protein, and from there HIV gains entry into the cell. There are 2 variants of HIV called HIV1 and HIV2. They both cause infection worldwide. HIV1 is the one that causes most infections around the world, and if people don't mention which one they're talking about, they're usually talking about HIV1. HIV2 is a special cause of HIV in places in Western Africa. Both cause sexually transmitted infections, both can cause AIDS. There are some differences in progression and severity, and there's one class of drugs called the non-nucleoside reverse transcriptase inhibitors that don't work on HIV2. HIV2 has a different reverse transcriptase, and these drugs don't work. The way most people contract HIV is through sexual transmission. You can also get it from exposure to contaminated blood. Sometimes healthcare workers contract HIV from a dirty needle stick. Also, when the virus first emerged in the 1980s, a number of people caught an HIV infection from receiving a contaminated blood transfusion. And then finally, the virus can be passed from an infected mother to her baby. For patients with chronic HIV, there are 2 main markers of infection that are followed clinically. The first one is the CD4 T cell count. This is determined by a lab technique called flow cytometry. A normal CD4 count is about 1,000. One of the definitions of AIDS is a CD4 count under 200. And the CD4 count can be followed to determine if patients are responding to therapy. It's also used to initiate prophylaxis against opportunistic infections. We'll talk about this later, but when the CD4 count falls below certain cutoff points, patients are more vulnerable to certain opportunistic infections. And the second main marker of infection is the viral load. This is a quantification of the HIV RNA level, and this is also used to monitor the effects of drug therapy and the patient's response to drug therapy. Let's talk about the symptoms of HIV. So the first thing to know is that the initial infection with HIV is asymptomatic in about 10 to 60% of people. And this is very unfortunate because it means that a lot of people are walking around with HIV and they can infect other people and they're unaware that they have the virus. Some patients develop an acute HIV syndrome. This occurs a few weeks after exposure to the virus. They will have fever and myalgias, also a sore throat and cervical adenopathy. Sometimes they get a maculopapular rash, and this is very similar to mononucleosis caused by the Epstein-Barr virus. And you have to have a very high degree of clinical suspicion to diagnose this. Otherwise, most physicians will think it's just a case of the flu or a virus, and they will not look for HIV infection. After the acute infection passes, or if the patient never gets the acute infection because they're asymptomatic, many years will go by with no symptoms whatsoever, and then they will develop severe immunosuppression and AIDS. The average time from infection to AIDS is about 8 years. The CD4 count has to fall below 200 to call it AIDS, or they have to develop an AIDS-defining infection, which we'll talk about in a minute. And once they reach the AIDS stage, the symptoms of the infection are not from the HIV virus, but they're from the opportunistic pathogens that infect the body when the CD4 count is very low. So this is a fairly classic graph of the time course of HIV infection, and it shows how the CD4 count and the viral load change after a person is exposed to the virus. So time 0 is where the patient is exposed to HIV virus, and the blue line here represents the CD4 count, which is shown in this axis over here. So let's start by following the blue line. So when the patient is first infected, the CD4 count is very high, up here around normal, about 1,000 or so. And then shortly after infection, the CD4 count falls. However, the body begins to fight back with CD8 positive T cells, and the CD4 count will rise somewhat, and then it will slowly drop over many years until it gets very, very low and the person develops AIDS. Now let's look at the red portion of this graph, which represents the viral load. Initially, it's very low, but then it shoots up quite high, and when it gets really high, this is when the patient can potentially get those acute HIV symptoms. This is when they're viremic and they can have that flu-like illness. Now the body begins to fight back, and it drops the HIV viral load to some low level, and then it slowly creeps up over many, many years, and then when the patient develops AIDS, the viral load begins to get very, very high. A couple of key things to recognize about this graph. First of all, you should know that when the viral load is very high here, that's when the patient can have acute HIV symptoms. The second thing to know is that this period of clinical latency, when the patient has no symptoms, but the body is fighting the infection, the most important cells right here are the CD8 cells. Those CD8 T cells are keeping the virus in check, and that's why there is this many-year-long latent period where the patient doesn't know they have an infection. Eventually, the CD8 cells can't keep up the battle, and the virus begins to win, and the CD4 cell count starts to fall, and viremia occurs, and the patient develops HIV. The other thing to know is that there is what's called a viral set point right here, where the virus sort of settles out after the acute phase. And that set point is different in different patients who are infected, and the lower that set point is, the longer you will have before you develop AIDS. Additionally, there is a point where the CD4 count sort of settles out after the acute phase when the patient enters clinical latency. The higher that CD4 count is, the longer it will take to reach AIDS. There are some rare features of HIV infection that sometimes occur. HIV patients sometimes develop dementia. The virus can infect macrophages and get into the central nervous system and also infect microglia cells. And there are a number of neurocognitive issues that HIV patients can develop. There is a pulmonary hypertension associated with HIV infection. The mechanism is not clear. And then finally, patients with HIV can develop a number of cardiovascular problems, including potentially a cardiomyopathy and heart failure. Let's talk about how you make a diagnosis of HIV. The old method of doing this was to use what are known as antibody-only tests. This would involve a screening test known as an ELISA test. This was sensitive but had many false positives. It was used to detect the presence of HIV antibodies. If the ELISA test was positive, a Western blot test was done for confirmation. This was a more specific test. CDC recommendations have changed, and the new recommendations advise using combination antigen-antibody tests. These are also called fourth-generation tests. These tests look not only for antibodies but also for antigens from HIV. So they test for presence of the P24 antigen and HIV antibodies, and these are believed to be more accurate for detecting infection. If the fourth generation or combination test is positive, then an HIV-1, HIV-2 antibody differentiation assay is performed. Two special situations in HIV diagnosis. If you suspect a patient has acute HIV, if they have that mononucleosis-like febrile illness, often the P24 and antibodies aren't elevated yet, so you can test for a viral load directly to see if there's evidence of infection in the patient. Second special situation is perinatal HIV. So the maternal HIV antibodies will persist for many months, and this will make any antibody test abnormal even though the child may not be infected. So the standard test for babies who may be infected from their mother is to do HIV PCR testing. Let's talk briefly about some of the opportunistic pathogens that cause infection in HIV and AIDS, and I talk about all of these pathogens in detail in other modules. Pneumocystis jirovecii causes a fungal pneumonia that is an AIDS-defining illness. When HIV first presented in the 1980s, otherwise healthy young men began presenting to clinics with evidence of this fungal infection, which had previously been extremely rare, and that was part of the way AIDS was eventually uncovered. HIV patients can get a CMV retinitis. They can get meningitis from cryptococcus. They can get a central nervous system infection by the protozoa toxoplasma. They can also get a severe diarrheal illness caused by the protozoa cryptosporidium. There are characteristic skin lesions called Kaposi sarcomas that are caused by the virus HHV8. This was another way that AIDS presented in the 1980s. Young healthy men began developing this lesion. Mycobacterium avium complex is a very rare cause of pneumonia in healthy people, but it causes pneumonia in people with severely depressed CD4 counts from HIV. And then finally, HIV/AIDS patients often get thrush in the mouth, which is caused by the fungus Candida. And in fact, an initial presentation of HIV is sometimes for a healthy person to come to their doctor and have thrush in the mouth. No healthy person should get thrush, and if you see that, you should think that the person may have HIV or AIDS. We give antibiotic prophylaxis for certain opportunistic infections based on the CD4 count. When the CD4 count falls below 200, patients are at risk for pneumocystis pneumonia, and this is when TMP-SMX is administered because it lowers the risk of pneumocystis. Below 100, we continue the TMP-SMX not only for pneumocystis but also for toxoplasmosis. In addition, in patients who live in endemic areas where the risk of histoplasmosis is high, itraconazole will also be administered. And remember, histoplasmosis occurs in the Mississippi and Ohio River valleys. When the CD4 count gets below 50, this is very low. These patients are at great risk of getting infected. At this point, we administer azithromycin, and that's because it lowers the risk of Mycobacterium avium. In another video, I talk about drugs that can be used to treat HIV infection, but let me just give you an overview here of how HIV treatment is generally done. Older guidelines that were in place when I was in training recommended treating based on the CD4 count. So for example, they would recommend not treating patients until the CD4 count fell below a certain level, usually about 500. Newer guidelines recommend treating all patients, and now generally all patients are offered therapy no matter what the CD4 count is. Multi-drug therapy is usually used, often with different classes of anti-HIV medications. This combination therapy is called highly active antiretroviral therapy, or HAART. And as patients are being treated with these drugs, their CD4 count and their viral load will be followed, and over time, sometimes the response to therapy will change. This is because gene mutations occur in the virus, and when this happens, the medical regimen will need to be altered. The last thing I'll mention is something called IRIS, which stands for the Immune Reconstitution Inflammatory Syndrome. So when you treat a patient with a low CD4 count who has HIV or AIDS, you reconstitute the immune system, and this means you can potentially see a flare of symptoms from inflammation. Remember that when the CD4 count is low, the inflammatory response is weak, but when you reconstitute the immune system, the inflammatory response can occur, and if there's a previously undiagnosed infection, you will see symptoms flare. So for example, if a patient has tuberculosis, they may have relatively few symptoms when the CD4 count is low, but when you reconstitute the immune system, they will get a vigorous immune and inflammatory response to the tuberculosis pathogen, and therefore they will get lots of symptoms. The same thing can happen if people have infection with any of these agents here. So this immune reconstitution syndrome commonly happens when you start to reconstitute the immune system, and the immune system is able to mount an inflammatory response to one of these agents I've listed on the screen. And that concludes our module on HIV.